We're very happy to have Dr. Tanya Vanderland and Dana Bisson with us. And Tanya was one who took the place of somebody who had retired when I talked about life changes. So, but Dana has been with the program since the beginning and has been the champion. So Dana and Tanya, I'll let you take it away. Thank you.
Thank you so much, Ann, and thank you for inviting us. The Concord Hospital Delirium Care Initiative has been going on since 2012, and you mentioned Dr. Lynn Painter, who retired, had initiated the program back in 2012. There have been a lot of parts, and we'll be mentioning some of those components, but we can't get into it in complete detail today. I'm an internist in Concord and see a lot of older patients, and that's by choice. I've always enjoyed taking care of older patients. I work with the population health team on trying to develop an age-friendly health system. Dana Bisson is a nurse at Concord Hospital who has taken on the role of a delirium nurse champion and works with operational excellence. So next slide. Our objectives today will be recognizing delirium and why it matters. We'll talk about the impact of delirium care on falls. We'll talk a bit about Concord Hospital's Delirium Care Initiative and also about sustainability, since you can't just do one-off projects. You need to be able to continue to improve and maintain gains that you've made. Just like Marie Cleary-Fishman and Ellen Flaherty talked about, we're trying to promote an age-friendly health system, and that includes knowing what matters to patients and their families and aligning care with what matters to them, trying to avoid high-risk medications and deprescribing as much as possible, and that certainly has been part of our efforts in the hospital. It means trying to prevent, screen for, and treat delirium in the hospital, and dementia and depression in the outpatient setting. And then ensuring that older adults are moving, because continuing to be able to take care of themselves as well as do the activities that matter most to them are affected by mobility. So I'll let Dana take over.
All right, thank you, Tanya. I'm very excited to be here and discuss how we're improving mentation here at Concord Hospital by focusing on delirium prevention and treatment. I just wanted to clarify that I haven't been here since the very beginning of the initiative. I kind of joined around 2017, although I've always been very, very interested in mentation since the beginning. So first, I wanted to make sure that we had a shared understanding of what delirium actually is. Delirium is primarily a disturbance in attention and awareness. This decreased awareness can be of oneself and of the surrounding environment. Depending on severity, these patients can be less aware of where their face is and where their face isn't, where their mouth is, if they're in pain, or if they have a full bladder. Patients with delirium often feel less hungry or thirsty because they are less aware of the sensory signals that tell them this. They can also be less aware of their surrounding environment. These are the patients that trip over the chair leg because they didn't see it. They misjudge where the sink is and fall, or they can be less aware of who or what is in the room. It develops over a short period of time, and it represents an acute change from baseline, and this often fluctuates in severity. There is also an additional disturbance in cognition. In my experience, this additional disturbance isn't disorientation as often as it is a change in visuospatial impairment or perception. If clinicians wait to treat only those patients who become disoriented, we're going to be missing a lot of people. We will review in more detail these additional changes in the next slide. Lastly, this complex syndrome can be the result of many things and often has multiple etiologies. We all know the usual suspects, of course: urinary tract infections, sepsis, hypoxemia, or electrolyte imbalances. But many do not often think of the other causes of delirium: alcohol withdrawal, for instance, or substance intoxication, including prescribed medications, which results in a disturbance of both A and C, is delirium as well. But this dry definition of delirium doesn't really get to the heart of what is going on, which is varying degrees of brain failure in our patients. So we know that delirium presents as a disturbance in attention and awareness, and in at least one other cognitive change. Patients can have memory difficulties and become disoriented. They can perseverate and often have disorganized thinking. Again, in my practice, I have found changes in perception or visuospatial ability to be the most common. This, in addition to difficulty thinking and poor insight, leads a patient to a high risk of complications, specifically falls. The disruption in the sleep-wake cycle is also important to note. That can be often the first indicator that the patient may become or is becoming delirious, especially in the elderly. The older brain is more susceptible, which Tanya will address in more detail later. People over 65, especially those with an additional underlying cognitive condition, such as Parkinson's or dementia, are much more susceptible to otherwise lesser insults, such as sleep disturbances. Delirium can be very difficult for teams to identify. Fluctuations are often present and can vary in severity. Changes do not have to be obvious, like the picture shows. Slight inattention or decreased awareness, then followed by improved attention and awareness, can be easy to miss, as you can understand. In the morning, the patient may look one way, and when you discuss it with a provider or therapist, they could reply, "Well, she looked fine when I saw her." It can make anyone, especially newer nurses or team members, rethink what they are seeing. Then, when the patient begins to fluctuate back towards their baseline, they think, "Oh, look, she's better now." These cognitive changes often fluctuate throughout the day, but it is easy for teams to explain it away. Evening fluctuations are common and are often referred to as sundowning. This can be confusing, as that is a term often applied to patients with dementia. One of the most common misconceptions is that if a patient has dementia and their behavior gets worse in the evening, this can't be delirium, but nothing could be further from the truth. As inattention is a cardinal feature of delirium, I just want to take a moment to ensure that we have a shared understanding of what attention is. A person that is attentive can select relevant stimuli from their environment. They can then focus on that stimuli and switch mental focus toward a new stimuli when appropriate. In delirium, a patient has difficulty with this, as shown in the picture. This is a picture of the ascending reticular activating system. In delirium, it is impaired, and it's this pink glob right here in the middle. I believe it's the key to really understanding delirium as well as treating the phenotype. It's a cluster of neurons located here in the brainstem. So if I can orient you to the slide, here's the brain, it's where the eyes are, hearing. It is a system of neurons that is a pre-conscious decision maker for the body. Here, various sensory tracts converge and then compete to become the overriding impulse. The job of this system is to allow important messages to pass through to the brain, as well as filter out messages that are less important. As you can imagine, if every sensory input was allowed to enter our brain and was given the same value of importance, we would not be able to focus or concentrate on anything. Conversely, if very few messages were allowed to pass through, even major ones important to our survival, we wouldn't be able to respond appropriately to our surroundings either. One major purpose of this system is to protect the brain from too many stimuli, as well as allow us to focus and shift attention when needed. As humans, we always think we are in control, but you can only be in control of what you're aware of. And this relies exclusively on a functioning reticular activating system. So notice what sensory tracts go through this system, because it's very important. Vision, hearing, pain, touch, and temperature all go through this system. And if this system is dysfunctional, the signals may not pass through. And understanding this, I think, is key to how we can treat the phenotype of delirium. The ascending reticular activating system is also important to a healthy sleep-wake cycle. It's central in changing our states of awareness, and it allows us to wake up in the morning, stay awake all day, and then sleep at night. The key takeaway: arousal is dependent on this system to activate the entire brain. It underlies the global broadcasting function of consciousness and awareness itself. I love this slide. So here are some of the many manifestations of delirium. There are 3 different subtypes: hypoactive, so when a patient is too sleepy; hyperactive, associated with heightened activity and sometimes agitation; and mixed, when you go back and forth. So delirious patients usually appear sleepy. This makes up the majority of cases and are what I like to call medically unmotivated. Due to a lack of sensory input, they often don't feel hungry or thirsty. They don't feel like washing up, and they certainly don't feel like taking a walk. In short, many of the things that will ultimately make them better. They typically are seen as the easier patient to care for. It's true that they don't ask a lot of questions and they don't ask for more attention, but they certainly aren't an active partner in their treatment plan either. They pose a risk to themselves as they are often less aware of food boluses going down or how to fully swallow. Anything that requires them to be aware, the need to reposition their bottom, if they're uncomfortable or going to the bathroom, is affected if a patient is in delirium. I once asked a trained LNA on our orthopedic unit, after I had explained all of this, what was a sign that a patient was in delirium? And he answered, well, when they miss their mouth with their spoon. And I thought that was a great answer. Hyperactive patients can pose an additional threat to others as well, especially if they are agitated. An adult with adult strength and a poorly functioning brain can really be a danger to anyone. In any case, delirium requires our immediate attention. Think about it. The fact that consciousness itself should be physiologically disrupted due to an acute medical illness attests to its clinical urgency. Next, Tanya will describe the consequences of delirium. Oh, Tanya, I think you're muted.
I kept trying to click the button, but there was a box there that was telling me to unclick the button and it was preventing me. Okay, here we go. So the consequences of delirium, they're manifold, Herculean, and we really need to understand that anything we can do to prevent delirium, shorten the course of delirium, and minimize the severity of delirium have a great impact on our patients. So delirium decreases the ability of a patient to be an active partner in their treatment plan. Often that means they are not able to follow instructions that staff give, requiring then a lot of staff interactions. Therefore, it results in a higher workload for staff. The patients with delirium often require 2 staff members to work with them, and whether that means having to move a patient that's not participating in standing, sitting, rolling over, or whether it means that they're swinging out at a staff member, that results in increased staff injuries. It's highly distressing to patients, family members, and staff. And there are reports of post-traumatic stress disorder in patients who have experienced delirium, as well as for their family members. If we look at the next slide, the consequences of delirium often result in a poor prognosis. So delirium proves to be one of the greatest independent risk predictors of poor patient outcome. So if we look at the next slide, we'll see that the cardiac ICU mortality in a study performed from December of 2012 to March of 2014 and showed that patients with delirium had worse outcomes. They only included patients who had a CAM ICU score. Among the 590 patients included, the prevalence of delirium was 20%. Overall, delirious patients were older, had greater disease severity, and required longer ICU stays. The patients with delirium had an average length of stay of 5 days versus 2 days in the ICU for patients without delirium. As you can see on the slide, patients who just had acute respiratory failure had a little over 10% risk of mortality. Those who had acute respiratory failure and acute renal failure, the risk went up to approximately 15%. And the global chi-square mortality rate was over 60 in patients with acute respiratory failure, renal failure, and delirium. The ability of those patients to go home was only 59% in those with delirium versus 85% of those without delirium. On the next slide, we'll look at a study that was presented in the British Medical Journal. It was also an observational study with 2 8-week periods of study in 2010 and 2012 in Oxford, England. The patients were screened for delirium using the CAM confusion assessment method and confirmed with the DSM criteria. They were reviewed daily during the hospital stay and then followed for up to 2 years. Of the 500 plus patients that varied in age between 16 and 99 and an average age of 72, half of them were male. Delirium, again, was present in about 20% of the patients, and the risk of delirium increased with age. The death rates were higher in those with delirium, and that risk persisted for 2 years past the index admission. So on this graph, you can see time 0 is the index admission, and the upper bars are those patients with delirium, and the lower bar are those without delirium, and that risk of mortality persisted over time. In that same article, they tracked falls, and they found that patients with delirium were 5 times as likely to fall. In a snapshot at Concord Hospital in 2017, we noted that 59% of falls were associated with delirium, prompting us to realize that delirium was significantly tied to falls within our own organization. So remember that patients with delirium have decreased awareness of their body and their environment. They're often inattentive and impulsive. And as Dana mentioned, patients themselves, family members, and staff often under-recognize the risk of these patients to falling. In an older study in 2008 in the Archives of Internal Medicine, the cost was estimated to be between $60,000 and $64,000 per delirious patient per year. So obviously, delirium is costly to organizations and indirectly then to all of us, since we all pay for healthcare. The biggest concern is permanent cognitive dysfunction. So we tend to think of people recovering from delirium, and although that can be true, it certainly is not always true. So in a Vanderbilt University study, they looked at over 800 ICU patients with documented delirium, and they tracked their mentation for 12 months after the study. So in this study, 6% of the 821 patients had cognitive impairment at baseline. So that means that most had normal cognition at baseline. Delirium developed in 74% during the hospital stay. The investigators did the repeatable battery for the assessment of neuropsychological status as a way of assessing this. And in this graph, you can see the box and whisker plots, which show the age-adjusted global cognition scores on the R bands with a population age-adjusted mean of 100 plus or minus 15. The lower scores indicating worse global cognition. And if we look at the light gray box in each of the 3 segments of the graph, the light gray boxes represent 3-month follow-up, and the dark gray boxes represent 12-month follow-up. For each box and whisker plot, the horizontal bar indicates the median The upper and lower limits of the box are the interquartile range, and the ends of the whiskers represent 1.5 times the interquartile range. Outliers are shown as black dots. The green dashed line represents the age-adjusted population mean for healthy adults, and the overall green band indicates the standard deviation. Also shown are the expected population means for mild cognitive impairment, MCI, and that's the red dash in the right-hand box. Moderate traumatic brain injury, or TBI, which is the light blue dotted line. And then mild Alzheimer's disease in the basis of other cohort studies, which is the darker blue dashed line. And in the right-hand box that we just have the red and the dark blue dashed lines because that's tracked only in older populations. So of the 820 patients enrolled at 3 months, 40% of patients had global cognition scores that were 1.5 standard deviations below the population mean, and 26% had scores 2 standard deviations below the population mean. So this means they had scores similar to patients with mild Alzheimer's disease. The deficits occurred in both older and younger patients. So on the left-hand part of the graph, it's patients that were 49 years of age or younger. The center part of the graph is 50 to 64, and the right-hand part of the graph is greater than or equal to 65 years old. The longer duration of delirium was independently associated with worse global cognition at both 3 and 6 months, and worse executive function at 3 and 12 months. Even among patients 49 years of age or younger with no coexisting conditions at baseline, 34% had global cognition scores at 12 months that were commensurate with a moderate traumatic brain injury, and 20% had results similar to those with mild Alzheimer's. Obviously, this is a serious burden upon these patients and their families. So at the next slide, we'll look at who's at risk. And the answer is many people are at risk. Certainly critically ill children and critically ill adults at any age. The very sick, the frail, or the very old adults are at higher risk. Anyone with pre-existing brain disease. And I think that's really important to remember, because when patients are admitted to the hospital or nursing facilities, if they carry a diagnosis of dementia or organic brain disease, we'll tend to attribute everything to that underlying disorder and tend to not recognize the delirium that's present on top of the underlying brain disorder. And I tend to think of this as kind of like acute renal failure on top of chronic renal failure. So this is acute brain failure on top of chronic brain failure. Anyone with significant sensory inputs is at higher risk. And remember that older adults have many conditions that cause vision loss. And hearing loss affects 80% of adults by age 80. So again, a very common problem that people are seeing in the hospital and the nursing facilities. So delirium is common, acute, can be reversible change in cognitive function that occurs as a result of physiologic stressors. So on the next slide, we'll look at delirium risk assessment. So we already talked a little bit about patient vulnerabilities and predispositions. That includes the cognitive impairment, advanced or very young age, prior delirium, hearing and vision impairment. Prior stroke puts people at higher risk. Impaired mobility puts people at risk. Dependence on alcohol and other drugs puts them at risk. Advanced cancer is a risk factor, as is malnutrition. People can then have acute precipitating conditions that increase their risk, and those severe illness, those include severe illness, and sepsis being one of the more common ones. Hypoxemia, of course, we are seeing a lot of that with COVID-19. Prior CNS trauma or being admitted with CNS trauma or disease. uncontrolled pain can cause delirium. And people can be afraid to give pain medications, fearing that it will worsen the delirium, but sometimes that's part of the treatment. Drug withdrawal is a cause that I think most of us are familiar with. Fluid and electrolyte imbalances. Anticholinergic medications are a key risk factor. And to remind you, anticholinergic medications are things like antihistamines, medications used for urinary incontinence, and some of the antidepressants and antipsychotic medications are commonly prescribed medications that people are on or are administered in the hospital. Anesthesia is a risk factor. Sleep deprivation is, and that's one of those double-edged swords. Both sleep deprivation and the medications used for sleep can cause delirium. So we're kind of between a rock and a hard place for that problem. Severe constipation and urinary retention are often overlooked and can cause delirium. And finally, tethers like IVs, catheters, and other restraints can increase the risk. So Dana's going to go on to talk about some of the management for acute delirium and what's required for best care.
Thank you, Tanya. So acute delirium management really requires a team approach. In order to make it sustainable, we need to ensure that administrators and clinicians are well educated in what delirium is, why it's important, and the tangible benefits to a targeted approach. We need to prevent delirium when we can, which is what we're going to discuss next. We need to screen routinely and to identify and treat all of the underlying causes once delirium is present. We need to try to treat the phenotype of delirium non-pharmacologically first. As far as medication management, we're not really going to get into that too much because there isn't any solid evidence that antipsychotics help. Our approach is, if the patient is displaying agitated delirium that is not responding to other treatments, low dose first generation antipsychotics at more frequent intervals is probably the safest. Obviously the safest being non-pharmacological first. So simple preventative measures, when they're done consistently, really do work. In a recent meta-analysis of non-pharmacologic approaches to delirium, it showed it significantly reduced delirium and showed a 62% reduction in falls. And we'll talk about specifically what was involved in those trials, I think, on the next slide. But if non-pharmacologic approaches are done to prevent delirium, not only is there a reduction in falls, but there's a trend towards a shorter length of stay, as you can imagine, and an annual cost reduction of $15 to $17 billion. It's a lot. So I've broken it up into daytime prevention and nighttime prevention. So techniques. So the goal for daytime prevention is to normalize wakefulness. Remember the back on the slide for the ascending reticular activating system. So you're going to want to do everything you can to normalize that system. So remember that vision and hearing sensory pathways are in that. So you want the patient to really understand that it's daytime. So you want those lights on and the shades up. You want vision and hearing corrected. So you're trying to optimize those pathways during the day so that it doesn't become dysfunctional. Face and mouth care should be done, again, to encourage attentiveness and awareness of their face and mouth. Getting them out of bed to chair for meals is really important. Not only is it important just moving the patient around, but also if they're starting to slip into a delirium, sitting bolt upright is really important for patients so that they don't aspirate, because they aren't always aware of food boluses going down. They're much more likely to aspirate their food or drink. Providing attentive activities, we're going to talk about a little bit later, but those are, we found, extremely important. It's not to occupy a patient's time, it's actually to, again, refocus that attentiveness while they're sitting there in the chair. Ambulation is extremely important, and we found at Concord that not everybody can ambulate. And so at least doing range of motion or sitting them at the edge of the bed or standing and marching in place, whatever we can do to try to increase movement in a safe manner is really, really important. Keeping them hydrated and encouraging oral intake is really important too. So sometimes these preventative strategies seem too easy. Everyone thinks they do this for their patients anyway. Of course, we don't leave them in the dark all day. Of course, we make sure they brush their teeth and they get up for meals. Of course, we offer them drinks throughout the day. But if you really dive into it, preventative measures happen less often than you think. In my experience, patients at high risk or with acute delirium present kind of present the perfect storm for not getting these things accomplished. They're sick, they're tired, they had a long night, their pain isn't controlled, they want to rest. Even when offered, they want to do it later. How often do we hear that? I'll brush my teeth later. I'll eat later. I'm not hungry. This is the majority of patients in our hospital, so we're accustomed to it, but that doesn't make it any less dangerous. It really is an art to getting patients to receive the necessary care they need to prevent and manage this dangerous syndrome. At Concord Hospital, we're working on managing these interventions visually, not only to increase team communication, but to hold each other accountable. We are lucky enough here to have a comprehensive therapeutic arts and holistic services department, which Alice Kinsler, who you'll hear from after lunch, created. It works very closely with the nursing department and other clinical staff. They tailor their treatment based on individual patient needs. And here are just a few of the services that they provide. Therapeutic music practitioners. They focus on an individual patient's need in the moment. They use music responsively, improvisationally, and intuitively to enhance awareness. Therapeutic artists play a real role in engaging patients in the moment and encouraging attention and awareness. Different mediums are helpful to individualized treatment. For my experience, the more colorful and bold and bright, the better. Reiki practitioners can play a significant role in the relief of pain or anxiety linked with delirium. We use it for hyperactive delirium to help calm patients, as well as hypoactive delirium, especially if pain or anxiety is contributing to it. Aromatherapy can engage the senses and allow some measure of control. Lavender, we found, is fantastic at relaxing and promoting sleep, which is a major contributor to delirium. Pet therapy dogs is probably our favorite and creates a sense of joy and can assist in returning a patient back to reality. The sense of familiar touch is extremely helpful in keeping patients engaged and present in the moment. We also have something called ABCD carts, it's named for activities at the bedside to curb delirium. And it contains all of the attentive activities you might want for patients in varying degrees of delirium. So they include sensory support, such as eyeglasses and magnifiers, art supplies, puzzles, and clay. We have drawers labeled mild, moderate delirium and severe delirium to assist nurses in selecting the most appropriate items. We have weighted cats and dogs, which has been a huge hit. We go through those extremely quickly. It's really helped the patients and it's really helped the staff. And I'm going to give you a quick example. We had a female patient here with dementia and hyperactive delirium. She needed IV fluid, but she had pulled her IV out. And she was hallucinating and had thoughts that she had a baby and her baby had been kidnapped. So as you can imagine, she was very agitated, very ramped up as any of us would be. And she was up and really walking very quickly. It was quite a dangerous situation as far as falls goes, going in and out of patients' rooms, going around the hallway, searching desperately for her baby. And we couldn't get her back into her room. This was extremely distressing for the patient, as you can imagine, and it was also upsetting to other patients and staff as well. Instead of giving her an antipsychotic, though, the nurse ran and retrieved a weighted baby doll that we had and wrapped the baby in a blanket. She told the distressed patient, "Look, I found your baby, but I can't hand them to you until you go back to your room and you sit down, for safety." The patient complied and took care of the baby for the rest of the evening, allowing the IV fluid she desperately needed. She even ate her dinner and drank fluids when we offered them. The staff kept her IV protected with a fidget sleeve, another Alice Kinsler invention, and she was discharged back to the nursing facility the next day with her baby, of course, much, much improved. What would have happened if we hadn't been able to give her that baby doll? The intent of this cart is not only to have different things like that, but necessary supplies for attentive activities just readily available for nurses on busy nursing units to have at their fingertips when they need it. Nighttime prevention. So nighttime prevention is extremely important and it's easily overlooked. Perhaps it's one of the most important things we can do for our patients. We need to really get these patients sleeping, and non-pharmacologic strategies are the safest approach. Providing face and mouth care, ambulating and emptying their bladder before bed really sets them up for a better night's sleep. Minimizing noise can't be overstressed. It's extremely important, and real steps need to be put in place to allow this. Sound machines can help as well. At Concord, we use a special white noise channel that comes through the patient's call speaker, because we had sound machines and they worked well, but they tend to grow legs and walk away. And this actually has the sound right next to them, and so it ends up drowning out a lot more noise. Nurses and clinicians can really lead the charge in this area. You know, do those cardiac monitors really need to beep all night right next to the patient? Is there a better way? Is there a way to also decrease hallway alarms in general? Tackling quietness, especially at night, is worth our time. It needs to be determined by the night shift though. So I'm a firm believer in the people closest to the patient and the ones doing the work should be the ones determining what that work is to really make it sustainable and affect change long-term. I also want to mention the value of weighted blankets, and you'll hear me talk about weighted objects a lot. Weighted objects can be extremely comforting, especially if they have anxiety, and I've seen weighted blankets work wonders. We use a comprehensive safe sleep order set here at Concord to encourage a good night's sleep. It includes orders for melatonin and other non-pharmacologic measures. We use lavender a lot, especially lavender aromatherapy. We also have available safe sleep kits that include lavender bags and nighty-night tea and earplugs and eye masks. Patients love them and we appreciate their value. The bottom line is sleep needs to be a priority. So those are the research-based prevention strategies that that study had looked at to see its effect on falls, which we can see was a 62% reduction in falls. So doing preventative strategies would be a huge thing for your patients if you do that. And so next we're going to kind of switch over to identifying acute delirium, and we're going to talk about identification tools. So don't be overwhelmed. I'm only going to stay on this slide for one moment. But as you can see, there's many tools available to identify delirium, and it can seem very overwhelming. There are diagnostic tools such as the CAN, or screening tools that have been validated. So I like to just encourage that you do your research and use the tool that works for your organization, just like Marie had alluded to at the beginning. The one thing you should consider is the clinician's ability to identify a change in baseline. So a patient's mental baseline, how do we know for sure? So medical teams and family members want their loved ones to be okay and at their baseline. In my experience, determining baseline can be difficult, especially in patients with baseline dementia or underlying cognitive dysfunction. I often use this example. I was told the patient was at their baseline. They had dementia, they were disoriented even at home. I walked into the room. The family was there and confirmed that yes, he was disoriented even at home. I asked the family what the typical morning looked like what could he do on his own? It turns out that he could butter his toast and eat independently. We looked at him. His tray was sitting in front of him, food untouched. His daughter asked him, "Dad, here is your toast. Can you butter it?" No, he could not. It was not because his arms were broken. It was because his brain was broken. He wasn't attentive enough. After aggressive delirium care, he became much more attentive, and before he left, he could again butter his toast. This return to baseline cognitive function is worth fighting for. Because delirium is easy for clinicians to explain away, we wanted to use a screening tool at Concord Hospital that was inclusive. Using a screening tool has made a huge difference in picking up all of our delirious patients, especially the easy to miss hypoactive ones. We use a tool that includes, but it doesn't require determining a change in baseline. But whatever tool you choose, make sure you educate to it and enlist all members of the team to help determine changes in baseline, as fluctuations can make it even more difficult to identify. Identifying the underlying cause. So we created an acute delirium order set that guides providers on evaluation and evidence-based management. It was created by members of the hospitalist team, psychiatry, and nursing to ease the workup and guide evidence-based treatments. So it has options for selecting if the provider wants to work the patient up with certain labs or imaging, hydration, pain management, sleep, constipation, agitation that requires medication management, thiamine supplementation, and also an easy way to order a palliative care consult. So we wanted something that providers could have at their fingertips when they were working up a patient for delirium. It kind of has three main benefits. It assists in determining and treating the underlying cause. It provides guidance on treating additional potential causes, such as lack of sleep, pain, thiamine deficiency. So oftentimes we identify the primary cause, but we don't identify the underlying causes as well. So the primary cause could be sepsis, but sleep is affecting it. Maybe some back pain is affecting it that we aren't treating, and something else. And so this kind of encourages the provider to look at all the causes and treat all the causes, not just the primary underlying cause. It also provides support in the management of difficult behaviors if non-pharmacologic approaches aren't working. So we found that very helpful already. And here are some general guidelines for managing acute delirium. So you're going to want to reorient frequently, speaking with the clinical team on removing unnecessary medications, collaborating with PT, OT, nursing staff, and providers to encourage early mobilization. Early mobilization is perhaps the most important part. Removing catheters and tethers, like Tanya had mentioned before. Monitor and treating urinary retention and preventing and treating constipation. Those are frequent causes of delirium. And although we know it, we oftentimes forget to bladder scan. So in our order sets, we have it there that, bladder scanning the patient just a couple times a day. The provider has different options to order frequency, but just to make sure that they don't have urinary retention that's contributing to delirium, because those two things are easily overlooked and can make things worse. Encouraging attentive activities for patients to engage in at the bedside. And this really is a team approach that we're going to get into. So once you identify that the patient is in delirium, remember to keep up those proven preventative techniques that we talked about before. But additionally, I'd like you to remember that the ascending reticular activating system at this point, if the patient is acutely delirious, you've screened them positive, is now dysfunctional. So encouraging attentiveness and awareness of the face and mouth frequently is really important. And you can do that with a washcloth on the face and kind of holding it there, and doing good mouth care. So encouraging awareness of the face and mouth is really important. And remember those ascending sensory tracts that will really help you in treating these patients. So use it to your advantage that you know what's going through here. So touch and movement can be extremely helpful in normalizing neurocognitive function. So think, how can I make them more aware of their face and their mouth? How can I make them more aware of their arms and more aware of their legs? Early and frequent mobilization, even if it's sitting the patient on the edge of the bed, like we said, 3 or 4 times a day, or standing and marching in place, mobilizing them to their capacity is extremely important. So here's some helpful tips that I found, and it all stems back again to that ascending reticular activating system. That's probably what you're going to remember from this talk. So here's some helpful tips. When you're working with these patients, you need to remove all distractions because they have a hard time selecting what's relevant. So the clutter has to be picked up in the room. If you're working with someone, you can't have that automatic blood pressure cuff going off or the SCDs going off and on when you're trying to get them to focus. That TV needs to be shut off too. We've found that the TV in general can increase hallucinations because they aren't able to, if someone's in acute delirium, they can't figure out whether it's real or not, and they can't get the full picture. Like not everything is going through that system at a normal speed, and they can't keep up because they can't predict what's going to happen next. It's not familiar enough. So familiar music is extremely helpful, we found, in patients with delirium, but having the TV on with the commercials and everything's trying to go through and compete, it's too much and it can actually make the delirium worse. Encouraging activities that promote and sustain attention. So coloring, for example, I don't like to use crayons working with these patients. It requires and same with colored pencils. That's great for someone if you're preventing delirium, but if someone is in delirium, that requires too much strength to push down and actually make a bright color. But markers help. So if you use markers or paint, but markers and giving them a simple picture that's not a childlike picture, but a picture that an adult might like to color, has to be very, very simple for someone in severe delirium, and it can be slightly more complicated if they have mild or moderate delirium. But encouraging them to do it is extremely helpful, encouraging that attention. So I usually ask them, you know what? The provider really wants you to color as part of your treatment for just 2 minutes, 3 times a day. Can you do this for 2 minutes? And they'll usually agree to 2 minutes and do it for 20, but you just have to get them to say yes. And then once they're coloring, they usually kind of can keep going. Simple puzzles we found help so that they can kind of focus and put it together. I like to use something called Model Magic. It's similar to Play-Doh. And when I'm in the room and I'm doing other things, I don't ever leave something like that with the patient because I wouldn't want them to get confused and choke on it. But I ask them, to make a ball. Here's some Model Magic. Can you make a ball? And get them to focus and using their hands and touch. Remember, it's all about that, to make a ball. Delirious patients can almost always make snakes. That's not hard. Balls are a little bit harder. You can ask them to pull it and stretch it. And then you can get them to do it even more, get them to focus even more by saying, pull it faster or slower. So you're getting them, wrap it around your thumb. You're trying to get them engaged and attentive using all of these different modalities. I know what you're thinking about cards. You're thinking, my patient is delirious. There's no way that they can play cards. But I'm not asking you to play cards with them. You could take a deck of cards and clear off the bedside table and very, very slowly put a card down and say, tell me every time you see a black card. Or tell me every time you see a 7. Or every time you see could be anything, a diamond. So you're trying to get them to focus and sustain attention like that. And you can make it as difficult or as easy as you want to. And going slowly is really important for them to really focus. Toileting on the schedule, we found, again, going back to the bladder and then oftentimes retaining urine, bladder scanning them as needed and toileting on the schedule. They often don't feel like they have to go. So us going in there and saying, oh, do you have to go to the bathroom? The answer is usually going to be no, until their bed alarm is going off and they're trying to climb out of bed and they fall. So it's really important to toilet these patients on a schedule and make sure that you don't ask yes or no questions. Do you have to go to the bathroom? You more say, let's try going to the bathroom now. Mixing it up. So I've actually found, I think of all the ways I can stimulate that reticular activating system. So bringing the patient outside or giving them a hot shower can really, really help become the overriding impulse and kind of wake up that brain. Assessing and treating pain. Oftentimes they won't report pain. So in one breath, the nurse will say, oh, I know they can't express pain the way other people can. And then the next breath, they'll say, well, they're not in pain because they said no. So it's really encouraging. Do they need maintenance Tylenol, something like that? Making sure that we're addressing and treating for pain as needed. Covering up the IVs, so we use something called fidget sleeves. So instead of them pulling out their IVs, we have these knitted sleeves with tags on them that the patient can kind of fiddle with, but actually not pull out their IV. Placing the chair next to the door is really important if they're impulsive, because you're closer to them, you can get to them faster. Anyone that walks by can see them right there. I love placing patients next to the window if family's there and they're safe. But for the most part now, I try to put them next to the door so that we can see them and get them engaged every time we walk by, make sure they're okay, because they can slip right out of those chairs sometimes. Engaging the patient, engaging the family in care is extremely important, and they're helpful. They want to help. They want to be able to do something. So you might say, Dana, there's no way I can color with them. I have too many things going on. You might not be able to, but their family might be able to. So just taking the time to educate and tell them what is acceptable and not acceptable. I oftentimes have family, if the patient's fine with it, encourage them to wash their face every couple hours, or play with cards. I don't usually have them do mouth care because they could aspirate on the water, but there's things that you might feel that they can do, and families really, really want to help. So sustainability. I wanted to take at least a few minutes to discuss how to make a delirium initiative sustainable. So this diagram represents how an organization must work together to function as a team and to drive exceptional care. Patients and families are at the center of why we exist. To optimize health, it takes a multidisciplinary approach to create actionable, realistic treatment plans. Management's role is to then support the process of improving care, which needs to be determined by the people doing the work. And this is key. If the people doing the work aren't coming up with a plan, it will not be as effective and it won't be sustained. Tying these initiatives into organizational strategies will ensure that it will be supported and sustainable for the future. So remember, delirium accompanies illness. So it will be important for us to have a strategic way to care for this complex syndrome long-term. And it can really have devastating impacts if we don't. So delirium isn't going away, but we can manage it much more effectively than we are doing now. Ensuring organizational alignment. So delirium is so prevalent and so devastating for both immediate and long-term health that it really affects all of these key areas, which organizations care deeply about. Make the case that delirium education, prevention, and treatment will provide tremendous benefits to patients and tie into your organization's strategic initiatives. Delirium affects 20 to 30% of medical surgical cardiac admissions, and it can affect up to 80% in the ICU. Tally just how many patients that is for your organization. We have discussed a lot on how delirium affects quality and safety. There's a lot of research over the past 10 to 15 years to support your case. I found it extremely valuable to take the time to study how delirium specifically affects our organization. Do that and then linking that to the national average, and you can show what it would look like if a delirium initiative is fully supported by your organization. Delirium affects flow of care, which is vitally important. Disrupted flow means that patients won't be receiving the necessary care needed in a timely manner. It disrupts their path to wellness. It also means that with 20 to 30% of patients affected, it delays discharge, which backs up the emergency department, full of patients requiring timely care as well. So delirium doesn't just affect those individuals. Delirium affects everyone. Delirium affects engagement as well, not just of patients who are less aware and motivated, and family who are scared and don't know how to help, but also staff who are overworked and sometimes injured. This can really affect morale. Cost is also vitally important. There are many studies that have tried to quantify just how costly delirium is to an organization. Tanya cited one study that found it is around 65,000 per delirious patient per year, but there are others. Tallying that up when making the case for why this matters can really help the long-term strategies. Educating staff first on what delirium actually is, like what is happening inside the brain and what it looks like, is extremely important. So it is not just linked to disorientation. Really describe how vulnerable our older population is, especially those with underlying cognitive brain disease. But don't discount the younger people. Remember, people from any age can and do get delirium. Once administrators and clinicians realize just how devastating delirium can be, most are usually hooked and want to become involved. Remember, it really is teamwork at its finest. From providers to nurses to transport and volunteers, everyone can play a role in improving safety for these individuals and improving outcomes. Too often our organizations offer a top-down approach. While we need leaders in our organization to set a vision, goals, and objectives, the work itself should be determined by educated staff who are closest to the patient. To foster teamwork at the bedside and support from management, a visual tracking system that shows a clear treatment plan and the individual status in that plan allows us to see in real time if the patient is receiving the care they need or if additional support is needed if they're not. And lastly, management support of any initiative is vital to the sustainability of the program. One of the most important steps in creating and maintaining leader standard work. All this involves is daily rounding to see what is happening and to listen to the staff, listen to the patients that are involved in the process. Tracking process and outcome measures and posting it somewhere where everyone can see how we're doing is really creates buy-in and makes them realize that this is important. Making it visual, discussing it daily, and discussing what's working and what isn't working and what we can do about it. Of course, this takes time out of a manager's 8-hour day, so strategic alignment is key to success. But if we're all working on the same key initiatives together, there will be a more dramatic impact. Caring for delirious patients really is an evolving area in healthcare. Strive for continuous improvement by encouraging incremental changes over time. Lastly, as you continue along this journey, share success stories often. There's going to be plenty of them. Recognize good work and appreciate your team. Thank you so much for having me and Tanya, and we will welcome any questions you might have.
So I cut and paste 4 questions for you and Tanya and sent them each to you. And just want to remind people that if you want to ask a question verbally, to go into the section on your lower tool that says reactions, and under that you can raise your hand and then we'll unmute you.
So one of the questions that I can answer already is somebody asked whether the weighted babies, cats, dogs were single use or somehow reused. And the answer is that they are single use. The patients can take them home. And again, for somebody with dementia, in addition to delirium, it actually can be quite helpful at home as well.
Yes, and we wouldn't want to take somebody's kitty cat away.
That's right.
after we'd given them their cat. And volunteers actually, Alice could probably speak to this too, but volunteers actually weight the animals for us. So we've bought weighted animals, and we've actually had volunteers do that as well.
So there are 2 questions regarding which delirium tools to use, and one of them was regarding a small med-surg unit, and the other is what's available at Cerner. So just to answer the second question first, we actually had to build the tool into our Cerner application. It was not available ahead of time. Within our own organization, Dana can probably speak to it some more, but Dr. Lynn Paintner and Dana did a small test of effectiveness of the CAM within Concord Hospital, and found that staff was missing hypoactive delirium frequently. They then trialed the Stanford proxy test for delirium, and that was more effectively picking up as a screening tool for delirium, not a diagnostic tool for delirium. So we have chosen to use that particular tool, but other common popular ones are the New Desk, and I think there's the 2-question UB, if I'm remembering the initials correctly, and certainly Dana can weigh in as well.
Yeah, I would just echo what you said. You really need to look at where your organization is at, and if you do choose something like a diagnostic tool, you'll want to make sure that staff can really pick up and understand the patient's baseline. We found it very difficult. We thought we knew someone's baseline, but it took a lot of effort to actually find out someone's baseline if they had an underlying cognitive disorder. And so our CNO at the time decided that she wanted to screen. She wanted to make sure we were picking up on all the delirium. And so we went with the Stanford proxy test for delirium, but there's others out there. Whatever works best for your organization.
And then the last question posed was, how is the Therapeutic Arts and Holistic Services Department funded? And Dana can also fill in details, but initially it was through grants processes, so getting funding through the Concord Hospital Trust, through other grant programs, and then it is also supported by our volunteer services program. And Dana, I don't know if you want to add to that.
Yes, and the salaries of the staff that work here was, part of Concord Hospital's, they found value in it, and so supported the salaries that way. So it's a whole bunch of different funding. Our hospital funded it, and we had grants that funded it, and we have volunteers. So we're always trying to work towards building that up. It's very, very valuable.
Alice, did you want to add to that at all? I know you, as the one who applied for many of the grants. I probably need to unmute her.
In the meantime, I'll answer another question. The one question was, how have you been able to use volunteers in a COVID world? Oh, we haven't. And of course, it's been a terrible year for our patients without those services. We do still have our ABCD carts. We still have our safe sleep bundles. So we're able to use some of the tools that we've had in the past, but it really has been noticeable within the organization, and puts a lot of burden then on staff, where volunteers were able to pick up some of that burden before.
Yes, we are starting to get, we just allowed therapeutic musicians who have been vaccinated back in, and that's been huge. So we're starting to get over the hump, but during COVID, there was no volunteers.
So if I can briefly add, yes, as Dr. Vanderlinde and Dana both said, the program has been funded by the hospital since 1989 and continued to fund it. And as we grew both in scope and in what we do, and the demand grew, I applied for a number of grants, primarily from the New Hampshire State Council on the Arts, and that was specifically to fund therapeutic music and therapeutic art. And I think the key is keeping it low cost, being creative, finding ways to make it sustainable without any additional funding, and very ambitious use of volunteers, both at the bedside, but also in the background, to do things like create those weighted stuffed animals, the puzzles, the fidget sleeves, and so many of those supplies. Thank you.
Yep, we miss you, Alice.
We miss you, Alice.
So as somebody who's trying to downsize children's toys and things in my household, I bagged up so many stuffed animals and gave them away. I wonder, do you accept if they're cleaned, or what's your policy for accepting donations in that area?
They
We
have
do
to,
it.
oh, I'm
Go
sorry.
ahead. No, it's okay. You can go ahead.
Okay. Of course, they have to be in good shape, but they do have to be cleaned before we accept them. And the volunteers who weight the stuffed animals, which, by the way, if you purchase them new, they're about $99 each. And we are committed, of course, to single use, and also to not denying anybody the use of it, but letting them take it home. So, so the volunteers cut open the seam. It's usually in the back. Usually they do it near the bottom, and they put in, it varies depending on the size of the stuffed animal, but they generally use something like rice. They put it in a plastic bag. They make sure it's dry. They put it in a plastic bag, seal it, and then put it inside the stuffing. They usually have to remove a little bit of the stuffing from the stuffed animals.
Yes.
Someone is also asking about the fidget sleeves, perhaps during the break and before my presentation at 1 o'clock, I will find some pictures of them. They are created by volunteers as well. They're knitted and crocheted, and they can have things to grab and touch and hold and pull built into them, or I should say, integrated into them so that you can't pull off a button, for example. So they're very safe. We make them in several different sizes so they can fit small arms and large arms. They are visually engaging, but most important is the tactile, and they cover the IV as well.
Yeah, they're fantastic. And as far as the stuffed animals, what we're finding for delirious patients, I think if you were doing it for children, that would be different. We really only want something that we don't really want a stuffed bear as much as we would like a cat to sit on the patient's lap, or a dog, or a rabbit, even a stuffed rabbit, but something that that has weight that they can care for. The baby doll was a separate thing that we ended up having, but anything that we can make weighted but looks realistic, the more realistic the better. That's what we're primarily accepting for delirious patients. We're trying to stay away from regular stuffed animals and going with something that you would have on your lap naturally, a cat or a dog or something like that.
And I think there's also the question, what are the treatment recommendations for patients who are discharged with residual cognitive dysfunction after acute delirium?
There's no research on that. I would encourage, if it was my family member, to do exactly what we talked about here. So it would be encouraging attentiveness, first doing all the preventative stuff, like the shades up, lights on during the day, making sure they're sleeping at night. So addressing sleep, making sure they sleep, getting them into a routine during the day where it's bright lights are on. Remember, delirious patients or people with cognitive dysfunction afterwards honestly tend to be medically unmotivated. I think that's the best term for them. And so they kind of want the shades down and to watch TV, but I encourage to do the opposite. So during the day, the lights on and the shades up, and making sure they're drinking and eating appropriately and moving. Moving is very important. They also don't want to shower a lot of times. They're medically unmotivated, so making sure that they shower maybe even once a day, so that you can encourage that. And then attentive activities. I have no proof that this would change the course of that permanent cognitive dysfunction. The fact that all of those patients had nearly normal cognitive functioning prior to being hospitalized, and that 12 months later almost no one returns to baseline is the most sobering slide we shared. And so there are no specific treatments for that, except this is what I would do.
Thank you, Dana. And there was a question asking what does ABCD stand for? And we used it to mean activities at the bedside to curb delirium.
Another Alice Kinsler contribution.
Team sport.
Team sport.
There's another question about whether or not you provide take-home written instructions, brochures for families when they take a patient home who has residual delirium.
So that is a plan of ours. At first, we've been working on making sure that what we're doing works here. But that is one of the things, is once we find a good routine that we can actually recommend afterwards, that we are definitely going to do that and share that and teach to that. That's one of our big objectives. So we can, permanent cognitive dysfunction is the thing that grabs, I think, absolutely everybody the most. And so we just want to prevent that from happening and to continue treatment once they're discharged, because we're certainly not going to wait for everyone to be out of delirium before they're discharged. That can take a little while. So they should go to an acute rehab and keep getting better that way, but they're going to have delirium there too. So kind of spreading the word on good delirium care. As soon as we have more, we'll be able to share that. And I also wanted to really stress, if I didn't enough, that the team effort it takes to treat these patients. So we have a visual management system here that once a patient is screened positive for delirium, we actually put a light on, over an orange light over their room, and it stays on the whole time that they're in delirium. And when they're out of delirium, we shut it off. And so transport has been educated. And when they go in the room and they see that orange light on, they do something differently. Even if the patient seems alert and oriented to them, they know they've screened positive somehow for delirium. And so they treat them as a high falls risk. They might transport them with their head up instead of all the way flat so that they don't aspirate. Everyone can play a role. So we've taught and educated as many as we could, from security to, the nutritionist to the food ambassadors. Everybody has a role. So when they see that orange light, that means something, and you just act accordingly. So it's a real team effort.
Yeah. And I will say we did have a brochure explaining what delirium was, because I think that's the first step, is patients and their families won't understand what it is. So explaining that they haven't suddenly developed new dementia or new schizophrenia with hallucinations. So at least a basic level of understanding.
Yeah, and it's neat to see how many people in the organization can now speak to some level to the patient's families on what delirium is. The LNAs feel comfortable sharing a little. The RNs feel comfortable sharing more. The providers feel comfortable. You start talking about it and it just becomes it's not a scary word anymore. We can say, are you having trouble thinking? Are you seeing things that aren't there? And they want to tell you about it. So it's becoming less and less of a scary word. It is for us because we know how detrimental it can be, but for the patient, they don't think that we think they're crazy. We just say, we understand this is extremely common and we know how to treat it. And it makes them feel better.
Thank you. So we have one final question, which I believe you answered partially in terms of just addressing the fact that it's really a team approach. Relative to all roles play a responsibility, but the question was about your typical staffing ratio for LNA nursing staff to accommodate providing these activities. It goes way beyond the LNA nursing staff, it sounds like.
Yes, so we have, it's not just, nobody thinks of it as their job. We all just try to do it. So we try to get the food ambassadors and transport, anybody that's in the room, if they could do 2 small things to tidy up the room, that helps. If someone's removing the tray from the room, they might bring back the marker, and transport might get them back into bed after they've had their chest x-ray, and then give them their marker and their coloring sheet and say, oh, you can start this. It doesn't take much. We certainly don't leave someone alone with clay or something that they could choke on, but I've seen providers that are getting them to color or getting them to do this, that, and the other thing. If it's just one job, it's not possible. But if everyone can do it and families can do it and transport can encourage, if everyone can encourage it, PT, OT, the PT will work with a patient, come back, get them back in the chair, and then, oh, here's your activity to do. It's fantastic if you treat it that way.